Morning, everybody. I'm one of the newest hirees with UCSF Trauma. I'm dual trained in trauma and arthroplasty. And today's talk is only 10 minutes on a topic that could take people hours to argue. And so the two talks that I would tell the audience to follow up, the Academy did a great webinar for the trauma fellows on this very topic, led by Joseph Patterson, who is a UCSF grad and has published extensively on the topic with Dr. Morshed. So I would recommend looking at that webinar. That's about an hour long. And then there is a talk by Dr. Morshed for IGOT that also I reference. So it's a broad topic. I'm going to specifically focus on young femoral neck fractures because I think geriatric femoral neck fractures have some clearer algorithms, and for the most part, the arthroplasty versus open reduction debate has been a little bit clearer for those patients. We're going to talk about current treatment guidelines and then the current literature on open versus closed reduction for these fractures. So just general epidemiology, there's like 250,000 of these cases every year. Lucky for us, most of these are in a geriatric population, but most of us are debating what to do in the younger population, and about 3% occur in patients younger than 50. This is a high morbidity fracture. 45% of patients will have a major complication, and about a third of them will require some kind of reoperation. The most common complications we're all familiar with are AVN and non-union. The biggest thing to come out of most research that's not very debated anymore is that quality matters more than anything else. So quality of reduction matters more than time to surgery, fracture pattern, displacement, et cetera. And the young femoral neck group demonstrated that a poor quality reduction increases a poor outcome by 5-fold. AVN doesn't really have an association with time to surgery. However, non-union does. So a delay of greater than 24 hours has a slightly increased rate of non-union. In terms of predictors of poor outcomes, there's a few. So a high Powell's angle, aka a more vertically oriented fracture line that is less likely to resist shear forces, location subcapital fractures, for example, degree of displacement and comminution all portend poor outcomes. And interestingly enough, a femoral shaft fracture is protective. There's some theories as to why that happens. Some is related to the force displacement at the time of injury going through two parts of the femur rather than just the neck. Others are the implant choice and decision on fixation using multiple implants may augment your femoral neck fixation. Patient factors, we all know, so age over 50 geriatric patients, 3 times higher risk of a poor outcome, but lucky for them, we have good bailouts as an arthroplasty surgeon. And then metabolic bone disease, alcohol, smoking, all have increased odds ratios of poor outcomes. So what's a good reduction? And that's the million-dollar question. So in the ideal, we like to say less than 2 millimeters of displacement and less than 5 degrees of angulation. Our tolerance for femoral neck fractures is a little bit higher, so less than 5 millimeters of displacement and less than 10 degrees of angulation. But there was a study published in the JOT 2009 that basically compared 5 different classification systems amongst orthopedic traumatologists with a series of femoral neck fractures that have been fixed. And interestingly enough, no classification had a higher inter-observer reliability than simply assessing it as good quality or high quality reduction and poor quality reduction. So it's a little bit like the Supreme Court case ruling, you know it when you see it kind of deal. So judging femoral neck foreshortening or varus malunion or fixation is more judged on a feel rather than specific tolerances or classification systems. So why do open reductions? Historically, open reductions were thought to relieve intracapsular tamponade, and so decreasing intracapsular blood volume decreased the intracapsular pressure, which led to less damage to femoral head circulation, decreasing your rates of AVN. that has borne out in lab studies and cadaveric studies, but has not really borne out in the literature in terms of associating long-term AVN or non-union rates with direct capsular capsulotomies. And then direct visualization of reduction quality. So like I said, multiple studies of different levels of evidence have argued well with significance that direct visualization of a good reduction matters. The cons are when you do open the capsule, you may damage the anterior vessels, and we've seen this picture today already. So these are dye studies on the blood vasculature to the femoral head, and we know that for the blood supply to the femoral neck, the inferior retinacular arteries that come off of the lateral femoral circumflex supply the neck, and the inferior retinacular arteries coming off of the medial femoral circumflex supply the majority of the blood supply to the head. So when you do an anterior approach, a modified Hoyter or a Smith-Peet, your retractor placement and where you make your incision with regards to the femoral neck can often indirectly or directly violate these inferior retinacular vessels to the lateral circumflex. So that's thought to be some of the reasons why we might have higher rates of complications even with a good quality reduction when we open up the femoral neck. In terms of treatment options, there's lots of implant choices, but we've had studies that demonstrate fixed ankle implants tend to do better in terms of failure rate. The FAITH trial, which is for any orthopedic resident tested extensively, demonstrated a slightly higher rate of AVN when comparing a fixed angle instrument versus a cannulated screw, but a lower treatment failure rate. And then Dr. Corey Collinge's group, the Young Femoral Neck Working Group, demonstrated treatment failure was almost double with cannulated screws when compared to like a sliding hip screw construct, or now what we use sometimes newer devices like the femoral neck system. Adding a medial neck support has a lower treatment failure rate, so a buttress plate along the inferior calcar or a screw percutaneously. And this was from Dr. Corey Collinge's paper. The lowest treatment failure when comparing multiple different fixation constructs was with medial neck support and an anti-rotation screw. So when should we open? The biggest thing is when you can't get a good quality reduction with closed reduction maneuvers. So when closed reduction maneuvers and percutaneous maneuvers with joysticks, Schanz pins, ball spike pushers, and things like that do not work. Or when you need medial neck support, that can't just be done by a percutaneous screw placement, when you need that buttress plate along the calcar. When you have a high quality read, that can be addressed with direct visualization. So if there's a key in the calcar that really you can dial in with rotation of the femoral neck and you can see it. Conversely, if it's a severely comminuted fracture and you don't think you can get a good read, there may be more of a leaning towards not opening that femoral neck. If there's extension into the intertrochanteric region or the femoral head, so if there's extension into the greater trochanter and you might need 2 implants or 2 devices to really dial in each reduction separately, so it's a neck and a greater troch fracture, you may want to open just to visualize both reductions so that you're not mal-rotating your 2 parts of the femur. And then if there's capsule entrapment, which again goes back to the first thing when closed reduction maneuvers don't work. This is from Dr. Morshed's talk. In general, when opting to do a femoral neck, whether you're doing it closed or open, it helps to prep the leg free, to bump it, to place the patient on a radiolucent table, and to not opt to have the leg strapped into a traction type setup like a HANA table or a fracture table, just so that you have the option to convert between your 2 techniques. And this is the adaptive surgeon model from the Academy webinar from Dr. Patterson. So you prep and drape the leg free. You do the Ledbetter closed reduction maneuver, which you can see in those videos. You maintain reduction with traction, and then you tune it with percutaneous reduction aids. Sometimes you might even need a mini incision to just dial in the reduction. You tune in, so you prep all your K-wires as you need to, so you prep them, and then you get your reduction, dial it in, evaluate. Obliques are going to be your friend in this, so you want to take multiple views just to make sure you're not getting a false view on an AP or a lateral. And then you decide, is this an acceptable reduction or do you need to open it? So what does the evidence say? And these are some studies from our very own here. This was an evidence-based update looking at open versus closed reduction. And the biggest takeaway from this was when comparing multiple studies of varying level of evidence, there was no significant difference in complications such as non-union, AVN, or all complications combined between open reducing or closed reducing femoral necks, and they were able to show a higher rate, statistically significant, of deep wound infection with open reduction, which makes sense. If you do an open reduction, you're gonna likely have a higher chance of a wound complication. Similarly, this was from Dr. Patterson looking at open reduction, and basically open reduction was associated with a 2.4-fold higher need for reoperation in open reduction. You can see that at all time points on a hazards curve. These are my references, and like I said, those 2 webinars on the bottom are really good to kind of delve into this topic in a larger forum. Thank you.